webinar, Plan, Do, Study, Act, Cycle Your Way to Continual Improvement with the PDSA model. So some housekeeping reminders before we get started today. If you're viewing as a group, please go to the chat window and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help with our final count. Some general reminders, all attendees are in listen-only mode. We want to hear your questions. So to ask a question during the session, use the chat tool that appears in the bottom right side of your control panel. Attendees will receive an evaluation survey after the webinar. Please let us know how we're doing and any new topics you would like us to cover. This webinar is being recorded and will be archived on our website. You can access previously recorded webinars that are sorted by topic by going to sbh4all.org/webinars. Our objectives today are to describe the two parts of the improvement model, identify who should be on the SBHC improvement team, learn how to set improvement aims, and learn how to develop improvement measures. Today's presenter is Ms. Laura Bray. Laura Bray joined the School-Based Health Alliance staff in October of 2000. During her tenure, she has served the organization in a number of capacities, including Director of SBHC Training and Technical Assistance, Associate Director, Director of Program Professional Services, and as of September 2013, Senior Training and Technical Assistance Specialist. In her latest role, she oversees all the organization's training and technical assistance initiatives, development of technical assistance tools and resources, continued education offerings, including monthly webinars and the annual convention, and executing professional service contracts and consultancies. Her 30-year career experience includes migrant health, public health, nonprofit administration, management, family planning, adolescent health, consultant services, training, coaching, technical assistance, and teaching at the secondary and college levels. School-based healthcare at the state and national levels has been the focus of her work for the past 20 years. She was the director of North Carolina's SBHC program, director of American Medical Association Guidelines for Adolescent Services in SBHCs, senior partner with Chicago Healthcare Management Consultants, director of Women's Ambulatory Care Programs for Faintus Healthcare Center, Cook County Hospital, and director of Bilingual Health Education Programs for the Illinois Migrant Council. Laura has a Bachelor of Arts in Teaching, French, Spanish, and School Health Education, a Master of Science in Community Health and Education and Administration from the University of Illinois in Urbana, and postgraduate studies in qualitative research at the University of Chicago. So without further ado, we're going to turn it over to today's presenter, Ms. Laura Bray.
Thank you. Hello, everyone. Good afternoon. What I have before you is an illustration. Okay, let me show my screen. I hope you all can see that now. This is the model for improvement. It's an illustration of what we're going to be talking about today. And it was developed by the Associates in Process Improvement. And it's a simple yet powerful tool for accelerating improvement in your school-based health centers or in any setting, but particularly we're talking about a healthcare setting. It's not meant to replace any other change models you have in place, but it can accelerate improvement and help you successfully, as many other organizations have, improved different parts of your healthcare processes or outcomes. So these are the two parts of the model. The three fundamental questions, which are what are we trying to accomplish? This is part one. What are we trying to accomplish? How will we know that we've made an improvement through our change? And what change can we make that will result in improvement? You can ask these questions in any order, but those are the three steps that you have to take and outline and put into an improvement plan before you even can start with the PDSA, which is what it stands for, is Plan, Do, Study, Act. And as you can see, that model for improvement or that improvement plan, the arrows show that you start with breaking those things down into planning and a whole carry out a plan. You do, you study, and you act. Okay, so let's move to the next slide. Okay, so let's talk about what we're trying to accomplish, or the aim. What is an aim? It's not just the bullseye that we have here. The aim is a statement that contains the explicit or overarching description that you are trying to accomplish. It's often identified with specific actions that will be taken to achieve that aim, as well as what we call a stretch goal, which is really a very large achievement because you may have many smaller goals and objectives that fall under that aim. It should also define the time-specific, it should be time-specific, like a year or 6 months or whatever that time period is, and it should define the population that will be affected by the change that you're trying to take on. And agreeing on an aim for everyone on your team, and we're going to talk about team later on, is crucial so that you have the right people to allocate to the work and the necessary resources to accomplish and achieve your aim. So here's an example. Let's take a look at this example of an aim. And we're going to decide, is it a good aim? So here's an aim. The clinic will improve its care for HIV/AIDS patients by making changes in the following areas: self-management and adherence support, decision support for clinicians, clinical information systems, delivery system design, community linkages, and leadership, focusing on education, prevention, and early intervention. So that's a large statement. So, is there an explicit overarching statement? Yes. What is that statement? It's the overarching statement that they want to improve the care that you're going to give. You want to improve the care for HIV/AIDS. Are the actions specific? Yes, the actions are specific because they're making changes in a number of different areas. So you know you're going to have a lot of goals and different outcomes because you're talking about self-management and adherence support, decision-making support for clinicians, the second one, clinical information systems is the third one, delivery system design, your fourth one, community linkages, your fifth one, and leadership is the sixth one. And then there's a secondary focus, too, on education, prevention, and early intervention. So there are many pieces to this aim. So later on, think about who are the right people you'd have to have on the team or at the table to make sure that you could address these issues and end up with accomplishing the goal you want to achieve or the aim you want to achieve, which is improving the care of HIV/AIDS patients. But here's an example of some goals. Now they become more time specific or they become measurement specific. And then you want to decide, how do you know if it's a stretch goal? Well, before you start with any kind of a quality improvement initiative, you set an aim, you have to decide where are we when we start. And that's sometimes the biggest flaw we have. When we start a new program or we want to make something better, we don't stop and measure where we are when we start or the baseline. And so if your baseline is 60% of the patients have one visit every 3 months of your AIDS patients, then you want to get to 100%. That's your goal. So 80% of patients would definitely be a stretch. But if you already are at like 75 and you set it for 80, that's probably not considered a stretch goal. So you want to be sure that you're measuring how well you are performing before you set your goal. Next, we will look at both in terms of patient care as well as outcomes. So we're talking about two different kinds of goals or examples. So is this time specific? No, it's not time specific because it doesn't say when you want to accomplish this by. But if we put on the word over the next 12 months or by October 29th, 2014, 80% of patients with at least one visit every 3 months, or will have at least one visit every 3 months, then we have a better goal because it's actually got a specific time period put onto it. Is it measurable? Yes, it's measurable because it's talking about percentages. So you've got to look at that baseline first and know if you can increase. So the first one is actually what we would call an outcome that's process-oriented, so it's visits. The second one is, again, a process because you've documented. But the second part, 90% have prophylaxis. That's a better outcome piece, but they're still not health outcomes. A lot of them are process pieces. So let's move to the next slide. So again, tips on setting aim. First of all, as I talked earlier, you have to achieve agreement and write the aim clearly. So that means that in terms of agreeing and making the best progress, you have to have everyone at the table who's agreeing that this is what we need to achieve for best success. So don't be quick. Make sure you set your team, which we'll talk about later. Also, make sure that you include number goals, which we talked about earlier. That would be reducing waiting time, for example, by 50%. It clarifies that you have to talk about a time frame within 12 months, for example. So numbers, time, instead of just we want to reduce waiting time. So make sure that you include numbers for the amount and the time frame in your aim. Second, set stretch goals. We talked about that. Again, remember, if you're at 40%, stretch it to 60. If you're at 60, try to stretch it to 80. So make sure that you're not overstretching, but not understretching. And then the fourth aim is avoid drift. And this means that you should think about not saying, oh, wow, you know, we can slip here. We want to reduce time by 40%. And then you say, wow, I remember that we were here to reduce 50% within 12 months, but pretty soon, you know, oh, we'll get to that next month. Or that unconsciously you don't address that need or issue. You only meet every quarter, and you go, oh, wow, we're not at 40% yet. So you have to continue to meet on a regular basis and keep working toward that goal in order to know where you are to achieve that 40%. So you don't want to drift and say, oh, gosh, 30% is good enough if we were going to try it for 40%. That's what we mean by avoiding drift. And then be prepared to refocus the aim. So every team needs to recognize that it needs to refocus if they're not able to meet their need within a reasonable amount of time, or they're finding out that things just aren't working right for them. So be prepared to refocus, and maybe you have to adjust that aim if it's not going to be something you can achieve. So don't confuse the aim refocus with drift. Remember, backing away from a stretch goal isn't a good tactic, but consciously deciding to work on a smaller part of the system is a good tactic. So if you can't achieve 50% of everything, can you break it down to something smaller to work toward achieving? So that's about the first question under the aim. The second question under the aim is, how will we know that a change is an improvement? So measurement is critical, part of testing and implementing changes. And they tell the team whether the changes they are making actually lead to improvement. So measurement and continuous measurement is really important for not only research, but for quality improvement. So here's a little bit, or a little chart that explains the difference between how we measure for learning and process improvement compared to research. Because a lot of people get confused between quality improvement being research. Sometimes it ends up telling us information, but it isn't about research. It's all about the quality. So the purpose of the improvement is to bring new knowledge into our daily practice, whereas research is meant to discover new knowledge. Tests. Many sequential observable tests so that we know what we're doing. You keep saying if it's making a change and all that. And then in research, there might be one large blind test. The mission is different. Biases. In a research study, you want to control for as many biases as possible. But in a quality improvement collaborative, you want to stabilize the biases just from test to test rather than for everything. And you don't have to do it overall from the beginning. You learn from what you did before, and then you change it into the next type of work you're doing to improve. So it is different from research. And in the data collection, we gather in improvement just enough data to learn and complete another cycle for improvement, or a PDSA cycle that we're going to get to next. Whereas in research, we gather as much data as possible just in case we need to use it. And the duration, research can take a very long time. But in process improvement, you may do a test for only a week, and you've got the data that you need to know, and now you can go on to the next level. So the small tests are for significant changes and an accelerated rate. There are different types of measures. I was addressing those a little bit earlier. There's outcome measures, process measures. And then we want to make sure that we balance outcome and process. So let's talk about measures. Outcome measures are those measures that affect the customer or our patients. They tell you whether there are actually changes that are leading to improvement to help us achieve that overall aim of reducing complications or improving outcomes. For example, in this case we've been using today for people with AIDS. They answer questions like, how is the system performing? What is the result? Examples including reducing a viral load or increasing a CD4 count, or in our study, increasing the number of students that are immunized versus number of immunizations is important, but number of visits is just, it's counting widgets versus actual achievement of an immunization. So those are outcome related. Process measures are measures of the workings of an actual system. So to affect outcome measures of reducing a viral load, for example, in the HIV case, or increasing CD4 counts, you will need to make changes to improve many core processes, the work that you're doing. It's not about the patient. It's about what we do in our work processes to achieve that goal, including self-management or the decision supports or the information or the medical record that we have or how we're delivering the care. That's what makes the difference for the process measures. So are the parts, steps in the system performing as planned? So if you measure results for process change, they'll tell you the changes are leading to improved care for patients. So yes, we have to make changes that are process-oriented in order to get to an outcome that's going to actually change the status of a patient. So again, measures of the other parts of a system. Balancing measures look at a system from different directions or dimensions, and they answer the question, are changes designed to improve one part of the system, causing new problems, or in other parts of the system? Using these measures to make sure that changes to improve one part of the system aren't causing new problems in the other part of the system. So that means if we're making this change in systems, are we causing a problem over here in our other part of the system? Are we not, because we changed so fast in our processes, are we not able to see as many patients? Are we not able to get as much vaccine? Are we not able to immunize as many patients? So we've got to balance those two systems in order to make things work. So we don't want it to result in poor care. That's the bottom line. So measurement. So when do we measure? What types and what time are there? So this is the example again of that PDSA, and you see that it's moving all the time. The data is always in a different place. So you start out with hunches and theories, and you're going to try them out until they come to a result in improvement. And so this picture will suggest you a difference between outcomes and process measures. It includes a new measure category called harm measures. Harm measures can be outcome or process measures that just suggest that there are measures that can cause harm to the patient, client, such as a nosocomial infection or medical errors. Outcome measures and measures of harm need to be constantly measured. Process measures, however, might come and go and are faster to learn from. A PDSA test, our measures are related to the specific test and are designed to learn more about one change that one is trying in a system. So again, you want to avoid these harm measures, and that's why you're always checking to see is what you're doing actually hurting the result, or is it helping you achieve the result? And based on what you find, you may have to adjust your measurement. Tips for measurement. Again, plot this data over time. Choose a few measures. That can be the single most important tool instead of all those measures. Remember we said don't collect as much data as possible. Only collect 1 or 2 or 3 and see how they change over time, and see if that's improvement, resulting in improvement because of the changes you may have made in a system. Are they giving you the results you want to see with the patient? Also remember, perfect is the enemy of good. So there's always this joke when I was coming up that good enough for government work, but that's not necessarily a bad statement. What this means is that we can't get everything perfect, but until we've achieved a really good benchmark, or we're approaching a good result, we don't need to have it perfect before we add on some more study or research to take us to the next level. And so don't let trying to get perfection hold you back from moving on and looking for other improvements. Also, sampling. You don't need to look at all the charts in an organization, for example, to know if you're having the outcome that you want. You can do a random sample of 10 charts, check what they say in terms of results, or go into 10 of your EMRs and look at how are you achieving different results from the system changes you've made. That's a sample versus in an actual research study, you would probably look at all the records, all the charts. So monitoring over time, 10 to 20 patients maybe per month, based on what the population you're working with may be a good sample to see how you're doing with patient outcomes. Also, make sure that you integrate measurement into daily routine. Today, with EMRs, we're able to look at real-time data much easier than we could in days past when we had paper charts, and we would have to pull those charts on a monthly or a quarterly basis. Don't wait till the quarter to look at what's going on. Look at certain measurements every day and see how it's changing. So for example, did you meet your quota for how many patients you were going to see today? Did the patients from that day get all of the factors you needed to do on your checklist? Did they all get their assessment? Did they all get the shot? Did they all get their blood pressure taken, their weight? Whatever you're monitoring and looking at, you don't have to wait till the end of time the end of a month to look at that. Look at it on a daily basis and give feedback and adjust accordingly, especially because you can do that on an electronic basis, much easier than you would have done prior with paper charts. Also, tips for measurement. Use both words and numbers. This refers to words being qualitative and descriptive and giving you people's opinions or feelings and expressions versus just numbers, because numbers may not tell you the entire story. So in order to do this, you may have to ask patients about how they're perceiving things. So you may, as the provider or as the director of a program, perceive that this is working really well. I'm happy with this. It seems everything's great. But that's only your perception. Or you might have all the numbers you want. But how does the patient feel about what's happening? What's their experience been? So the only way you're going to know that is to see if your perception, your numbers you have, your perception from feeling is accurate by talking to them and seeing if they are satisfied with the service. Did they feel that they were talked to nicely? And the patient's experience is as good, if not better, than it was before. If you're seeing more patients, you don't want to do it at the cost of reducing patient satisfaction, for example. And then the third question of that aim is, what changes can we make that will result in an improvement? So the ability to test and implement changes is essential for any group or organization. And there are many kinds of changes that will lead to improvement. So don't think that you can only have one improvement. Measure all the different things that may come out of your study and anticipate what you can do that could result in improvement, such as not only more patients seen, for example, but a better rate of compliance, better satisfaction, And how are you going to see that all those things lead to improvement? So basically what we're really saying is that not all changes lead to improvement, but any improvement effort you're going to take on requires change, and that you must look at and plan a lot ahead of time. So that's why I was talking earlier about an improvement plan. So that's the first step in the process. So this is a slide of an improvement plan that you will receive after this webinar. It's a template to develop an improvement plan for any effort that you're taking on. And it walks you through step by step what to do. In addition, it also gives you an example of how to set up an improvement plan. This one has to do with best clinical practices for obesity prevention and using health ed resources. And it looks at basically what is the aim, enhancing obesity prevention and treatment, what is the current situation, so what's your baseline, and what's the desired goal or stretch goal you want to get to. Now this may not have actual measurement in it, but if you look down at some of the objectives in that, they actually have more specific measurement in them. So by such and such a date, all primary care providers, or 100%, things like that. So this just gives you an example of how you might want to set up and begin to look at an improvement plan. And then there's an actual blank one for you to fill out to help you do one. So now you've got the bigger, broader aim, and you have the improvement plan set up, the measurement set. So now you want to look at what is a PDSA cycle. So the PDSA cycle is a shorthand for testing a change in the real work setting by planning it, trying it out, observing results, and acting on what is learned. This is a scientific method used for action-oriented learning. So the plan, the PDSA cycle starts with planning. What's your objective? So you're like a scientist. What are we trying to accomplish was the bigger one, but what is the objective of this first cycle? So if I'm trying to, for example, I'm trying to improve the HIV care for patients. But the objective I'm going to start with, well, I'm going to improve the number of visits. That's one piece of the pie. In order to improve their care, I've got to bring them in at least every 3 months. So my objective is to do that. So questions and predictions. So what do I have to do to get to having them come every 3 months? Why aren't they coming? And then I begin to do some predictions about if I do this, I will be able to get my patients to come in every 3 months or increase the number that come in every 3 months. And so maybe you want to take the patients that aren't coming in every 3 months and begin to work with a subset of them and do some extra added-on activities like reminder calls that you may not be doing, or outreach to them by an email or some other way of reaching out to them and seeing if that makes a difference in getting them to come to an appointment, let's say. And then you say, well, let's do that with 10 of these patients. And then the doing it is carry out that plan. So how long does it take you? Maybe it took you, 2 weeks to see what happened with those 10 patients. And then you look at those results and you begin to analyze the data. And then you say, wow, maybe you talked to them and they didn't come because of X, Y, and Z. So you analyze, why didn't they come? You compare what actually happened to what you thought. So you thought if I did this, I could get them to come in for their visit. And so you summarize what you learned. So you have to really plan out, what do I want to test in the shortest amount of time? And then based on those changes, you're going to try to create a new PDSA cycle that you're going to change it slightly. Instead of how am I going to get more patients to come in, tweaking what you may have done wrong or adjusting and see you try it on again. But if it was working really great the first time, you may actually want to change that and increase the sample and see if it works for a larger sampling and see if that's going to help you get closer to that goal. So once you know that you've done enough of these PDSA cycles over the period and you've achieved that one benchmark of getting patients closer to having 3 visits, so you've moved from 60% to now 80% of patients having a visit every 3 months, and you think you have a strategy in place, you can move on to something else. So repeated use of the PDSA cycle, this is basically what I just talked to you. You're going to start on a very small scale, so this is an illustration of that. You're going to follow up and test out with those smaller samplings. And if it's good and you've adjusted and you're getting the achievement you want, now you're going to start to do it with a wider scale and continue to see if that works until you feel that it's benchmarked or the implementation of change has happened and you've gotten the result you're looking for. Or, as we said earlier, maybe it's not perfect, but it's good, and it's the best benchmark you think you can get to for right now. So why do we test? Testing provides the opportunity to increase yours and others' belief that change will result in improvement. You've always heard of the naysayers. There's the people that, oh, we'll do this, it won't work. But in order to do that, you have to increase or get buy-in. We always talk about before we do a quality improvement effort, we have to get the buy-in of the people that are working on it. So they have to believe that their change is possible and improvement is possible. And write those expectations down. And then how do you minimize resistance? You try to work with those people to get them on board. And minimizing resistance means, well, I don't want to change. Well, you don't have to change totally. Maybe you're just willing to try it on this one time. Work with us. Put aside this thing. Or don't look at the rules and the regulations. Let's put that aside for this one test. We're going to try something a little different and act out of our comfort zone. And based on if they have a positive experience through that, by working through resistance or sort of like running with resistance and helping them get through it, they may learn and adapt and see, wow, that wasn't such a bad thing and it really did result in something better. And you have a turnaround. You have a new believer, a new convert. And then you have to go on too and look and evaluate the costs and side effects from any of the testing you did or any of the changes to make sure that it provides you with a benefit that outweighs any costs or side effects you may have had. So you can use a flow sheet to look at how you're going to do all of these different tests. Again, going back to starting small and doing more. So cycle 1, based on flow sheets and tests of one patient. Now you want to maybe test another doctor's patient. So you're starting with one, now you're going to go to another. See if there's any difference. Present your flow sheets and decisions on maybe 3 clinicians now and get their feedback. And revise and test the flow sheets with maybe all the patients for 1 week. And again, this is how you're increasing that number that you're working. And then once you reach, again, your improved decision support, this is one area of improved decision. You realize each provider is having that. Then you can implement and monitor the standards. So everybody's benchmarked at one level. So this is a provider-based piece. So let's go through some PDSA tips. Scale down. Scale down means that usually we bite off more than we can chew. And we may say, oh, we need to test this out for a year. Well, a year may be too long. If you tried, like a lot of times we overestimate or we think we need more time. So in order to promote rapid change, sort of this rule is try to see if you can drop it to months. Maybe instead of a year, try 6 months. If it's hours or even minutes, reduce it back to, like, if we're going to take this for an hour, let's take it for a half an hour or 15 minutes. So try to think about time frame and trying to take that time frame down 2 levels. So one of the things outside of healthcare in meetings, we think, oh, we need an hour for that meeting. Well, let's take it in half at least. Maybe you can't drop that meeting down by 2, but can you drop it by a half? And see if you have a well-planned, scaled-down meeting, can you actually do it in 30 minutes? And I know in our organization, we've learned that we can do a lot more in less time if we plan well. And then we're spending more time on other things. So the same thing is here. Let's see if we can't do it quicker and faster and see what we can do within the time frame. The next lesson or tip is oneness. Don't try your test in every school-based health center or with every provider or with every patient. Oneness, conducted in one facility or one office, or try with one document, one patient at first, and use that like your pilot and see what you need to do to change. Or maybe you start with 3, but the bottom line is keep it small until you've got it right. And then you expand to the larger population. PDSA tip 3, changes in parallel. When you look at that improvement plan, you're going to have, as in this example we've been working through with HIV, you're going to have multiple objectives and changes, thus PDSA cycles, going at the same time. So you're not just doing one PDSA cycle for the whole improvement plan. You've got PDSA cycles going on for self-management, PDSA cycles going for delivery system design, decision support, the information system, how you're working with your community resources, leadership. So right here alone, there's 6 different ones going on over the course of that year. And so remember, you have to keep all the balls going in order. And that's why you need different team members and those that can take the lead and take charge for different ones, because not everybody can do the same thing. So here's another illustration for PDSA cycles that I think will be helpful to you, because it really spells out the key questions you need to ask and define for every PDSA cycle in terms of the planning, where you define the system, assess the current situation, and analyze causes and things like that. So it'll help you walk through how you can actually do a better job of planning, a better job of carrying out that improvement hunch that you have or that theory, and studying the results, and then how you can act upon what you've learned, and then do another continuous improvement and change what you did wrong and start over again. So this is another handout that will be sent to you guys at the end of this presentation. In addition, here is a PDSA worksheet to help you plan out every PDSA cycle based on what we've talked about so far, as well as the questions in the PDSA cycle. And you can use one of these for each PDSA cycle you're doing in each of the different change areas that you're going at the same time that make up your improvement plan. And we found this tool to be very helpful for sites planning this out. So the other thing I wanted to share with you too is about the, a tip 5 would be how do you look at whether you're going to look at whether you're ready for the change, you're indifferent or resistant. So how to look at if there's low confidence that the current change ID will lead to improvement, or high confidence. And then you have to rate, is the risk of the cost of failure large or small, and is the cost of failure for high confidence loss or small. So these are all the different ways that you want to weigh whether the change is worth it or not. So many want to know why. If they know the idea is a good one, they cannot just implement the idea. You know, it's like just, we need to be convinced. How can we be convinced? So this attempts to help answer these questions, encourage us to look at the current situation related to how well are we willing to accept the idea? How well do we think if we do this that this change will take place? And are we willing to take the risk of the cost of failure? Is the cost of failure too large? Maybe we don't want to do it. Maybe we need to revise. For example, if the current situation contains a high resistance to change and there's low confidence in or evidence of success related to that change, and the cost of the failure is high, then the test that you're going to take on should be very small, so minimal risk. Sort of like if you're investing. You know, you don't put all of your money in really high-risk stocks, for example, if you know that the cost of failure is very large. When you, even if you have, and if you have low confidence and high cost of failure, you may not want to do the test or the evidence at all. And then if you fail, how do you resign and make changes so that you lessen the cost of failure? Okay, now we're going to talk about teams. The team is really important in quality improvement. You can't make a change alone. So what is a team? A team is a small number of people with complementary skills committed to a common purpose, and they want to set or perform certain goals and approach for which they hold themselves mutually accountable. Every team member has to be accountable. So you have to pick the right people to be on your team. It's important that the size, it's not so much always about the size, it's about the expertise. So one person may represent all the system issues you're going to address, including your sponsor. So the system people that you put on a team are those you need there to have your organization support. They can allocate resources. They can give you the the rules, the okay to do something, the ability to say if this works you can change. So they're really the person with the that you have to have buy-in to begin with, and that you know you've got what you need, what we call organizational support. So that may be one person, that may be two people, or it could be more. Technical, that's the expertise you need to make sure that you're doing the tests correctly around the content area. So if you're doing something in HIV, you need to make sure you have someone who's a provider who knows about the HIV pieces. If you're looking at the management system or the EHR, you've got to have the technical expertise of the people that do that data system and management. If they're one and the same person, which isn't likely, you know you're going to have already at least 3 people on your team. And day to day are the people that do the work. That could be the administrative people that register patients. It could be the clinical support staff, the patients. It all depends on the work that you're doing. So for example, right now across the country we're working on a collaborative quality improvement piece. So in terms of system support, it's around implementing substance abuse screening, alcohol screening, intervention, treatment, that type of thing, called ESPERT. So for the system, you've got to have the managers of those organizations bought into it, as well as the school, because if the school is not working with you on this, you may not be successful. So you have to at least have those people on your team. Technical, they've got us at the national level and other expertise around the content area, providing them with that kind of expertise. And also on a daily basis, they have the primary care providers as well as the behavioral health providers working on that in the clinical setting. So there's a bunch of different technical people on the team. And day to day, they have to look at how are they scheduling the appointments? How are they entering the data? Who's doing the work? And also the primary care provider and the behavioral health provider play a double role because they also are doing the work on a day-to-day basis. So that team could end up being 3 people, 5 people. It depends. But you have to make sure that you're looking at what you're trying to accomplish and you have all the right people there to help you do it. And a team practice tip is, instead of big meetings, this has been started in our organization, let's have a team huddle. And that means where we get the team together that's working on an issue. And we ask them if they could meet for 10 or 15 minutes. And we really want to work around a certain issue that we're having some problem with. We want to build it into our day. So we need to talk about this, and we want to talk about it right away. And then we may go back and work on something. So it may only be 10 minutes. But we're bringing that group together because we realized, or our team leader realized, because there has to always be a team leader, the best person who is going to convene us, make sure we get together, write up the minute, all that kind of thing. The team leader is usually that person in your organization. It doesn't have to be by content, it's by skill. And so after 15 minutes, they know the set objectives and what we're going to work on, and we've got our marching orders, and we go off and do the work. And we can accomplish a lot more than having another big hour-and-a-half meeting that we only hold once every 2 weeks. Better to address the issue right away, and frequent huddles can lead to quick change results as well and quality improvement. Team practice. Don't write big, long reports. Have a system in place where there's shorter, more frequent times to write up the findings, talk about what's worked, what didn't work, and document that. But you can do it with bullets, not paragraphs, so that it makes it easier to read, easier for people to produce, and you can move more quickly through this. And another tip is to ask for forgiveness, not permission. So sometimes we're already so stuck in rules and regulations. Oh, we can't do that because this rule says this, or we can't do that. It's more, can you just forgive us this time for not doing exactly and meeting the norm because we want to try out a new rule? And so that may take some time to test in a current environment, to test something new and different. But you don't necessarily need permission, you need forgiveness, because it's not going to be always perfect. Tip number 4, learning with others. Your team is, and all the other people, if you've got a whole group of you doing it across different sites, you are a learning community, and you are learning from others. That's why they call this, through a lot of this work is through learning collaboratives. So we are greater than, one person can't do it alone, and we achieve a better outcome, and we learn from each other. So always keep that in mind when you're doing this type of work. I wanted to share a web resource with you. It's a long email, but it will be on the archive as well as the PDF that we send you at the end of the webinar. But the Institute for Healthcare Improvement, IHI.org, has lots of resources around quality improvement. Much of this presentation, the ideas, did come from their website. I've been working with PDSAs and projects like this that we described today using the IHI model since like 2000. And they have lots of resources for you that can help you if you want to pursue a quality improvement piece and you're looking for more tools. Also, some of the references for the presentation go all the way back to the Deming model. And that's where the whole concept of the PDSA was formed. It was related to the automotive industry and in engineering. So here's the two books by Deming about that. And then taking that and translating it into actual healthcare, the improvement guide. There was the recent second edition. The first one came out in the 80s, and there's the second edition in 2009 showing how this work can happen in the healthcare setting. Okay, Erin and Chelsea, do we have any questions?
Thank you so much, Laura. We do not have any questions at the moment, but we want to open up the floor to anyone who does have questions. If you go to the right-hand side and at the bottom of your panel, you should have a chat box. If you have any questions about anything Laura's presented on today, go ahead and type those in now while we're kind of doing some concluding marks here.
And let me just say one more thing to the group. So this is sort of a fundamental starter workshop. Just to introduce you again, those of you who have not done PDSAs, who have not done an improvement plan, have never used this, to introduce it to it. And then throughout the next coming months, we will be having several different options for healthcare PDSAs around some changes you may want to make. So consider this a building block. If you don't get it, you're confused, you have questions, please feel free to email me or contact me. I'll send you to some more resources. We'll send you some more examples of PDSAs that have been done or improvement plans that we've done or others have done in the areas you're interested in, help you work through it. So do we have anything?
We don't have any questions that have come in on our end yet.
Okay.
It looks like something just came in. Give me one moment. So the question we have says, can you give advice on how many people and who exactly should be on a QI team?
Okay. Well, as I mentioned before, it depends upon if this is a general QI team for your entire school-based health center or on a specific project. So I'll answer it in two ways. QI teams should always have at least 3 people in general, no matter what you're doing. And so if you looked at the school-based health center, you want to have someone from leadership of your sponsoring organization at a minimum, someone who can make decisions, give resources. You don't want to do something that cannot really be implemented system-wide. Second, because you're in the school setting, you should have someone from the school, a school administration, school counselor, whoever, depending upon how it's going to impact your integration into the school. And thirdly, you need to have staff that do the work. And depending upon the type of work that you're doing, if it's related to primary care, behavioral health, you may need 2 providers. Or if it's the whole system, you might need the oral health provider if you have that as well. But you need to have the provider represented. And then usually those are the minimum 3 because we're in a school. But I would say, too, you need to have your support staff because they're critical as well. So you need to have that represented. So again, as I mentioned before, that's the minimum team is at least 3. And because you add on the school at all, you've got 4. And then in addition to that, you really want to take a look at, some school-based health centers only have 3 staff or 2 staff. So you're probably going to have all of them on it. But you really need to look at what are we trying to accomplish and who do we need to have on the team. And make sure that, again, going back to those questions of, do we have the system person we need in place? Do we have the technical content expertise represented on this team? And do we have the day-to-day operations person that's related to this, or people on the quality improvement team? And then one of those people has to become the leader, who's the convener, who calls the huddles, who does the reporting, keeps the taskmaster, who keeps us going. Any other questions?
Okay, great. Thank you, Laura. We do not have any questions at the moment, so we're going to go ahead and get to some concluding reminders. Oh, one question just came in. I lied.
Uh-oh, not lied.
Any suggestions for me on the school side, approaching providers in the SBHC who may be hesitant to have assessments?
Can you read that again?
Sure. Any suggestions for me on the school side, approaching providers in the SBHC who may be hesitant to have assessments?
Okay, so I interpret this as mean that they're afraid of being evaluated or having their work assessed for improvement. I'm not sure what you mean by having assessments, but quality improvement is not meant to be punitive, and that's the piece we have to be sure that we're working on, how we can learn from each other and get better. So we understand that we're not all perfect. Remember, forgive me, I'm not perfect. And so that in order to be bought in, you have to guarantee there has to be that systems person in the collaborative who's saying, we are not going to hold this against you. This is an effort to get the whole system better, and that you want to buy everyone into the improvement so that they know they're all going to be better in the end. And if you don't know how to do it as best as this other person does, we're going to have that. Let's say this nurse practitioner can do that work better than you. Well, that instead of being afraid of that, let's learn from that. And so it's a positive way to have the nurse practitioner come and show, well, I meet this benchmark by doing this. I'm going to teach you some of my techniques, and you can learn from me, and you can benchmark to where I'm, and you'll get better. And the whole system will get better. So again, it's a learning community. It's part of teamwork. And the team is only as good as the quality of all its players. So if that was a correct interpretation, was fear of being assessed and judged, think of it more as not judgment of just, it's a benchmark of how you can get better. It's a positive thing, not about your deficits, but about your assets and learning from other assets. Because you may do something else better in that assessment where you're going to teach your colleagues.
Great. Thank you so much, Laura. So at the moment, we do not have any more questions, but we do encourage you to keep popping them into the chat box. But for the sake of time, we're going to go ahead and move on to some concluding reminders. So we want to remind you that our 20th anniversary convention is coming up in Austin, Texas. It'll be June 16th through the 19th. Call for abstracts are now open. The deadline is November 3rd, so go ahead and get those in. If you're not already a member, we encourage you to look into it, to become a member with the School-Based Health Alliance. We have 2 options, individual and organizational, and if you'd like to learn more about membership and the great benefits, you could log on to sbhforall.org/membership. So again, it doesn't look like we have any more questions. If you do have any more, feel free to go ahead and type them in here. If we're not able to answer those in the next moment or so, we will certainly get back to you or have Laura email you. So some closing reminders here. This presentation has been recorded and will be archived on our website within the next 2 to 3 days. You can, if you have any questions or need technical assistance related to the PDSA model and improvement, please send us an email at programs@sbhforall.org. So we just want to say thank you so much for attending today, and a special thank you to Laura Bray and her great presentation. If you have additional questions, comments, you can contact us at programs@sbh4all.org. Thank you so much, everyone. Have a great day.